Welcome back to CMB Bite Size. Today, we are breaking down one of the most significant shifts in cardiovascular management, modernising heart failure in primary care, specifically navigating the new 2026/27 GP contract changes and the early four-pillar paradigm. Before we dive in, please make sure to hit that like button, subscribe to the channel, and share this video with your practice team so everyone is on the same page. If you want to follow along or present this to your own PCN, you can download this exact slide deck using the link in the video description below. Disclaimer: this video is produced for educational and informational purposes only and does not constitute medical advice. Clinical decisions remain the sole responsibility of the treating healthcare professional. CMB Communications assumes no liability or indemnity for any clinical decisions, diagnoses, or treatments made based on this content. Let's get started. We are looking at a revolutionary leap in how we manage heart failure in the community. Today, we'll align the latest clinical science with the financial realities of the 2026/27 GP contract. To understand the why behind these changes, we have to look at the clinical burden. Heart failure remains the only major cardiovascular disease with an increasing prevalence here in the UK. Despite historical interventions, the prognosis for patients with heart failure with reduced ejection fraction, or HFrEF, has remained persistently poor. Symptoms severely impact our patients' quality of life, driving frequent hospitalizations and a high mortality rate. The clinical imperative is clear: traditional management is simply no longer sufficient. For years, our standard treatment algorithm relied on a slow, stepwise introduction of medicines. Step 1 was initiating an ACE inhibitor, or ARB. Step 2 introduced a beta blocker. And Step 3 was essentially wait for symptom deterioration before considering further therapies like MRAs. This sequential titration was heavily reinforced by the old QOF framework, specifically isolated indicators HF003 and HF006, which actually rewarded a fragmented approach to therapy. But the 2026/27 GP contract represents a definitive break from that legacy management. NHS England has initiated a broader systemic shift to modernise CVD care. As part of this, the historical stepwise indicators, HF003 for ACE inhibitors and HF006 for beta blockers, are being actively retired. Those 12 points are not lost. They are being reallocated directly into a single, unified measure of clinical excellence. Enter the new HF009 indicator. The retired points fully fund this new measure, carrying a weight of 12 points. The target is a 20% to 50% achievement threshold. What are we measuring? The percentage of patients diagnosed with HFrEF who are currently treated with the full, NICE recommended four-pillar therapy. This is not an administrative tweak. It is a contractual mandate to align primary care with evidence-based medicine, designed to drastically improve survival. Of course, before we optimise treatment, we must accurately diagnose. Primary care is the vital front line for early detection. Patients presenting with breathlessness, fluid retention, or extreme fatigue require immediate investigation. NICE Quality Statement 1 mandates that adults presenting in primary care with suspected heart failure must have their NT-proBNP measured. That NT-proBNP measurement confirms if heart failure is likely and dictates the urgency of specialist intervention. A high reading, between 400 and 2000, mandates a routine referral for specialist assessment and an echo within 6 weeks. A very high reading of over 2000 triggers the urgent referral pathway, requiring specialist assessment within 2 weeks. This rapid triage directly lowers the risk of acute hospitalisation. Symptoms and blood tests alone aren't enough for a definitive diagnosis. The specialist multidisciplinary team must conduct an echocardiogram to confirm cardiac dysfunction and categorise the phenotype. This splits into HFrEF at 40% or less, HFmrEF between 41% and 49%, and HFpEF at 50% or more. Chronic management strategies and your QOF indicators diverge heavily based on this confirmed ejection fraction. This brings us to the core clinical paradigm shift. We are moving away from the sequential, wait-and-see introduction of single drugs. The modern mandate is early comprehensive therapy. Adults with HFrEF must undergo early initiation of all 4 foundational pillars, tailoring the sequence to the patient but establishing baseline therapies before optimizing individual doses. This multi-pathway blockade synergistically reduces cardiovascular mortality. Let's build that foundation. Pillar 1 is your ACE inhibitor, ARB or ARNI. Crucially, the 2025 guidelines update means sacubitril valsartan, an ARNI, may replace an ACE inhibitor for symptomatic patients and can now be initiated by primary care, considering specialist advice. Pillar 2 comprises the beta blockers, essential for controlling heart rate and reducing sympathetic nervous system overactivity, titrated upwards carefully. Next are our modern additions. Pillar 3 is mineralocorticoid receptor antagonists, or MRAs. Previously reserved for later stages, these are now first-line essentials. Pillar 4 represents the most significant recent breakthrough, SGLT2 inhibitors. Dapagliflozin or empagliflozin provide powerful metabolic benefits and cut hospitalization risk, regardless of diabetes status. Together, these form the complete, optimized defense for HFrEF. While HF009 focuses on HFrEF, our clinical ambition extends further. Historically, we only had loop diuretics for symptom control in mildly reduced and preserved ejection fraction. But NICE TA902 and TA929 fundamentally changed this landscape. Dapagliflozin and empagliflozin are now recommended as disease-modifying options for these symptomatic patients. Note: if empagliflozin is considered one of a range of suitable treatments, guidelines advise using the least expensive option after discussing advantages and disadvantages with the patient. Achieving 4-pillar optimization is a shared responsibility. The specialist MDT diagnoses, manages decompensated patients and is responsible for optimizing treatments. However, primary care takes over the routine management, ongoing prescribing and clinical reviews only after the patient has been stabilized and their management optimally titrated by the specialist team. Remember, communication and clear handover protocols are essential to prevent clinical inertia. Aggressive early therapy requires vigilant safety monitoring. NICE Quality Statement 4 dictates that adults with chronic heart failure must have a clinical and blood review 1 to 2 weeks after any change in the dose or type of their heart failure medication. This rapid 1 to 2 week review cycle is crucial for monitoring renal function, electrolytes, and blood pressure, as multiple therapies are introduced. Once established and optimized, care transitions to long-term surveillance. NICE mandates a comprehensive review at least every 6 months for stable patients. Furthermore, all adults with chronic heart failure should receive a personalized, exercise-based program of cardiac rehabilitation, complete with psychological and educational support. So, how do we secure those 12 points allocated to HF009? Practices must systematically audit their HFrEF registers. Here is the action plan. Step 1. Identify all patients coded with HFrEF or LVSD. Step 2. Review prescriptions against the 4 pillars. Step 3. Address gaps. Initiate missing therapies for stable patients locally, considering specialist advice for ARNIs or code exceptions. And Step 4. Escalate. Refer newly diagnosed or decompensated patients to the specialist MDT for initiation and dose optimization. The transition to early 4-pillar therapy is a revolutionary leap in cardiovascular care. Retiring stepwise QOF indicators for the new HF009 isn't just bureaucratic shuffling. It is the financial alignment of practice sustainability with life-saving clinical science. By embracing this, primary care will reduce hospitalizations, extend lives, and secure vital practice funding. Thank you for joining us to review the future of heart failure care in general practice. If you found this breakdown helpful, please give the video a thumbs up, subscribe for more clinical updates, and share this with your colleagues. Don't forget, you can download this complete slide deck for your practice via the link in the description. Once again, this content is for educational purposes and is not medical advice. Clinical decisions remain the responsibility of the treating professional, and CMB Communications accepts no liability for clinical practice decisions. Thanks for watching, and we'll see you in the next one.
Like and subscribe.